In cases of large atrial septal defects that cannot be surgically closed due to severe pulmonary hypertension, the management focus shifts from closing the hole to protecting the patient's heart, lungs, and overall daily functioning. This clinical situation, often called Eisenmenger physiology, requires a multi-system approach centered on quality of life, symptom control, and proactive complication prevention. The core principle is to avoid closing the defect if pulmonary hypertension is severe and irreversible. In this state, the ASD acts as a vital pressure relief valve. Closing it could cause critical pressure overload and worsen right heart failure. Therefore, the clinical strategy focuses on conservative, supportive management, including medical therapy, lifestyle optimization, and ongoing surveillance. Targeted therapies for pulmonary hypertension aim to reduce pressure and improve exercise tolerance. Doctors may prescribe endothelin receptor antagonists, PHOS, PHO, DIESTERASE5 inhibitors, prostacyclin analogs, or soluble guanylate cyclase stimulators. While these medications do not cure the underlying condition, they can meaningfully improve symptoms, walking distance, and daily functioning. Managing heart failure symptoms is a priority. Even with the ASD open, the right heart may be strained. Clinical interventions may include the use of diuretics to reduce fluid overload, oxygen therapy if levels drop, iron supplementation to address deficiencies, and the careful avoidance of high-risk medications that could worsen the cardiac shunt. Preventing complications is essential, as patients are at risk for arrhythmias, stroke, hemoptysis, and heart failure. Clinical recommendations often include targeted anticoagulation in specific cases, staying up to date on vaccinations like influenza and pneumococcal, and strictly avoiding dehydration, high-altitude travel, and pregnancy, which carries a very high risk. Lifestyle and daily function optimization can significantly enhance quality of life. This includes engaging in moderate, supervised physical activity while avoiding strenuous exertion to prevent spikes in pulmonary pressure. Furthermore, patients should avoid temperature extremes, seek psychological support to manage the emotional burden of chronic disease, and optimize their nutrition to maintain energy and reduce fluid retention. Regular follow-up with a multidisciplinary team is crucial. This typically involves a pulmonary hypertension specialist to manage medications, a congenital heart disease cardiologist for structural tracking, and periodic diagnostic assessments, including echocardiograms, 6-minute walk tests, and oxygen monitoring. This team-based approach allows for therapy adjustments as the patient's condition evolves. When symptoms become severe despite maximal medical therapy, clinicians may discuss advanced options such as lung or heart-lung transplantation. Because these are complex and rare procedures, they require evaluation at a highly specialized medical center. The pathophysiology of an untreated large ASD involves a decades-long cascade. It begins with chronic left-to-right shunting that recirculates oxygenated blood. This leads to massive, relentless pulmonary volume and pressure overload, eventually resulting in structural vascular damage, such as fibrosis and muscular hypertrophy. Closing an ASD in the context of Eisenmenger syndrome is highly unsafe. Severe pulmonary hypertension causes a reversal of the shunt from right to left. In this state, the ASD becomes a vital escape valve that decompresses the right side of the heart. Closing it would block this route and likely trigger fatal pressure spikes. Medical teams carefully evaluate closure safety using tests like measuring pulmonary vascular resistance. Generally, closure is only considered safe if resistance is low. Other tools include vasoreactivity testing, temporary balloon occlusion during catheterization to observe cardiac response, and the use of fenestrated devices to reduce shunting while maintaining an escape valve. Thank you for watching this video on the management of complications in untreated large atrial septal defects. We express our deepest gratitude to everyone who participated in this exploration of clinical care and patient wellness.